So, dear colleagues, ladies and gentlemen, we like to welcome you all for this lecture. Uh, we are proud to have Professor Atiq Zaman with us. He will talk about tuberculosis in spine, management-wise, and how to approach that. Dr. Atiq Zaman, he is a very well-known orthopedic spine surgeon in Pakistan. Unfortunately, we could not be joined by Professor Amr Aziz because he's really, we wish him all the being well. He has some tonsillitis. So Dr. Atiq will be our main lecturer. We will talk in sections, and after each section, we can answer a few questions, and you can either raise your hand or type your question in the chat or Q&A, and we'll answer after each section. Hopefully, we'll not exceed the 1 hour limit, and we will wish you enjoy this meeting. Dr. Atiq, Professor Atiq, please.
Thank you very much. Thank you, sir. So we are going to discuss the tuberculosis spine, and our plan is that after the introduction, I will give you the lecture, and we have the question and answers in between the lectures instead of at the last. And then we have a take-home message, and we will close this session. The tuberculosis is very important for the Pakistani people because our founder, Muhammad Ali Jinnah, was died because of this disease. And although the history of the tuberculosis, it dates back to the Egyptian era, but in the modern world, this spine tuberculosis was introduced in 1779. Unfortunately, still we are receiving this type of deformity which was present in the Egyptian era, and the humankind is still not able to control this disease. And we are seeing the disastrous presentation of the caries spine. So the learning outcome of this presentation is that we will deal it in 3 sections, the clinical features and the investigation, and then we have give you the chance to ask the questions about it. Then we will discuss the medical treatment, and then we will discuss the surgical management. So this is the first case for you. She is a 45 years old female. She has presented with the pain in the lower back with the anorexia and weight loss from the last 3 months. And there is no neurological loss. And if you see the magnified view of the X-ray, you can find that there is the destruction of the whole L4 vertebral body. And the part of the body, it is lying anterior to the L3 vertebral body. Right. This is the MRI, which also shows the same findings, and part of it is also compressing the spinal cord. Also, the patient have pain but did not have a neurological loss. So the question from is it that which one of the following is your diagnosis for this patient? Number 1, tumor. Number 2, tuberculosis of the spine. Number 3, bacterial infection. And number 4, the osteoporotic collapse. You can, at the bottom of your screen, if you bring the cursor at the bottom of the screen, you will find the chat box. Just write in the chat box or in the question and answer session your answer, and we can see that.
Yeah, but don't be influenced by the name of the lecture, please.
This was the catch you have told. Okay.
Yeah, waiting for your answers, please. We'll give you about 60 seconds to answer.
You can guess wrong, no problem.
Yeah, exactly. We need your opinion only.
There's only salam from Abdullah Shah. Welcome, Abdullah.
We have 3 answers. 4.
It is in the chat box.
Yes.
Okay.
So, as expected, mostly we have TB.
So we have done the posterolumbar interbody fixation with the screws, and this is not the TB. This was a tumor lymphoproliferative disorder on the biopsy, and even the radiologically, it is not the TB. TB is like this. There is the end plate destruction, and usually the disc is going to be spared, and there is a soft tissue shadow anteriorly, which is not present in this case. Right? You can see that the end plates, they are normal of the upper and the lower vertebral body, and whole of the body has been destroyed. And even then, the kyphosis has not been developed in it, which is in case of tuberculosis, if the disease, even it has been healed, it causes the local kyphosis there. And there is an end plate destruction, and that end plate destruction, it goes into the facial planes, and then it causes the fusion. So you can easily diagnose on the basis of the radiology that whether it is a tumor or it is a TB. And the most important thing is the paravertebral shadow, which is the abscess, right? These abscesses, if that is present, you can suspect the tuberculosis. It can be the retropharyngeal abscess in the cervical region. It can be a widened mediastinum in the upper thoracic region. It can be a fusiform swelling in the thoracic region, or patient can present with the was abscess. CT is not very helpful in the diagnosis of the tuberculosis. Only it shows the calcification in the pus area or in the caseous material. The MRI is basically the most popular and most diagnostic tool for the diagnosis for guessing the tuberculosis. And you can see that there is a soft tissue shadow, there is end plate destruction, the disc is spared, and this caseous material and necrotic tissue which is compressing the spinal cord. Even in the healed TB, you can find out that it is different from the tuberculosis. The only differential diagnosis is the in case of this radiological finding is the bacterial infection. On the basis of the X-ray and the MRI, even you can diagnose that, you can guess that whether it is a pyogenic or it is a tuberculosis. If it is a pyogenic, usually there is a single vertebral focus, there is a symmetrical collapse. You will not find the gibbous or the kyphosis in case of the pyogenic infection. It spreads intraosseously and it destroys the disc. It will not involve the end plate usually. It is present in the blood vessels, and then it causes the destruction and it involves the disc. And it usually involves the anterior column, and there will be an epidural abscess, which is more common. And most important thing, that it is acute in onset, which is contrary to the tuberculosis, where there is a multi-segment involvement, there is kyphosis, it spreads along the facial planes, the disc is sequestrated, it usually involves the anterior and the middle column, and sometimes the posterior column, and there will be a paravertebral abscess in it instead of the epidural abscess, and it has a chronic onset. So history, examination, and the investigation will help you in the diagnosis. For the clinical features, usually the patient has the chronic bearable pain. Patient remained in pain for quite a long time before he developed the other symptoms. Although he had the constitutional symptoms like fever, malaise, and weight loss. And if the disease is progress, patient can present with the kyphotic deformity or the neurological deficit. These are the list of investigations, and these investigations, they basically help with the if we use it in collaboration with each other. Right? You have to go through most of these investigations, like lymphocyte count might be increased or it may be normal. Patient has increased ESR. The Montos test is in endemic areas, they're usually positive because of the vaccination and because of the previous exposure to the tuberculosis. Chest X-ray is helpful in the diagnosis because usually the primary TB is in the lungs. The Zeal Nansen staining and is not very helpful because most of the time it comes out to be negative. The tuberculosis culture, it takes too much time, usually 6 weeks, to give you the results, which is also not very helpful. Now they have devised some cultural dishes which can grow the tuberculosis early, but even then it will take some time and it will not give the proper results. this histopathology and this gene expert test, the PCR, this is basically a revolution, because even if you send the fluid, pass a small amount of tissue, it can give you the results within days. And they are very sensitive in diagnosing the tuberculosis. The rest of the tests, they are not very helpful and not commonly used in our practice. So you should keep in mind the differential diagnosis when some patient it will arrive in endemic areas like in Pakistan. If we have all these features, our first thought is the infection. But in other areas, you can think of the pyogenic or fungal infection. Brucellosis is also very common. Then you can think of the different primary or the metastatic tumors. Deformities can mimic the tuberculosis. Similarly, the sarcoidosis and the osteochondritis, they give the similar picture on the clinically and the radiologically. So why the diagnosis is so important? See this patient, he is holding his head with his hand. He cannot, is not stable, his neck is not stable enough that it can bear the physiological loads. And he was in a pain from the last 6 months. And if you see the X-ray, because the quality of X-ray is not so good, even then you can see that there is something going wrong at the C5, C6 level. And because the soft tissue shadow is not very prominent in this X-ray, but there is a soft tissue swelling anteriorly if we see retrospectively. And if you see these MRI, you will find that the anterior neck is full of fluid anteriorly. And when we perform the surgery, we go anteriorly, and there was a fountain of pus which came out from the neck. So this is basically the delay in diagnosis, because this is an insidious, slow, progressive disease. It is a cold abscess. The patient has a bearable pain, so he keep on going with this disease. And if the doctors, they do not have in their mind that the tuberculous spine can behave like this, they can easily miss the tuberculosis. So we have done the anterior decompression, removed all the vertebral bodies and replaced it with a cage. This is another patient who has, he's a 40 years old female whose D12 and L1 vertebral body distraction has occurred. And this is the video to show that usually the tuberculosis do not have a frank pus. It has a caseous material. When you give, this is the incision which is given in the paravertebral soft tissue, and this paravertebral, after the incision, this caseous material, it comes out from it. This is the diagnostic of the tuberculosis. I will not think of any other thing except the tuberculosis in my patient if I see this caseous material. So again, the anterior decompression and cage has been done in this patient. This is the 40 years male who had the destruction of this D10 and D11. And see that there are pus pockets have been formed around the thoracic and the lumbar spine. So the tuberculosis, it spreads along the paravertebral tissue. And I am sure that to whichever doctors he is consulting, they have not done the clinical examination of this patient, and that's why he has reached at this stage, that he has areas full of the pus pockets. And it is very easy to diagnose it, because you can put a needle and you can see that there is a infection, there is a pus, and it needs the incision and the drainage, and you can send the biopsy from it. This is another patient. This is not the same patient. And look, when we give the incision to it, the amount of pus coming out from the body, and this amount of pus, it shows that we as a doctors, we are missing something which should be diagnosed early. And TB can take some time to look at the pus. So, because this pus has been developed very slowly, so the patient bear this pain, and he thought that it is simple low back pain, and even the doctors, they are treating it like the simple infection, so we can miss the diagnosis. The purpose of showing these videos and these patients is that this is the pathology that can be easily missed. So keep in mind that the tuberculosis, especially in the endemic areas, is the most common cause of the spine infection. And after the lungs, the most common organ which is involved is the spine in the tuberculosis. And then we have done the anterior decompression and the cage in this patient. Before I move towards the next towards the indications of surgery, if somebody has any questions about the diagnosis, they can ask. We can spend 5 minutes in question answers.
Yes. Thank you, Dr. Atiq. Dr. Atiq, I have a question. You know, it's not endemic in Jordan, for example, but we don't have the PCR for the TB. And once we suspect that, it's more common to see sarcoidosis in our region. Is there a way to do?
Actually, there is definitive diagnosis on the histopathology. They will find the granuloma in the histopathological section. There are because when this bacteria, its cell wall, it is going to be invaded by the macrophages, which are lymphocytes, which converts into the macrophages, and then these macrophages, they convert into the giant cells within 2 or 3 nuclei, and they engulf this bacteria, and then they produce the necrotic material. This whole thing, which is happening at the microscopic level, it can be seen on the microscope, and that is the pathological for the tuberculosis. So biopsy is the ultimate answer for the diagnosis. Of course, the PCR and the gene expert test is a revolution, and it has helped a lot. But if it is not available, and it was not available in Pakistan even a year back, so you can do the biopsy. And if there is other indications of surgery, we will discuss it later on in the next chapter. But if there are other indications of surgery, then you can go for the surgery, take the biopsy, and send it for the biopsy. If there is no other indication of surgery, then you can do the CT guided or endoscopic guided biopsy. Nowadays, people, they are doing the endoscopic guided biopsy, so that they can take the tissue from it. And if you have taken the proper biopsy, of course, the histopathology can diagnose the tuberculosis very easily with the help of the granuloma. Hope I answered the question.
Yes. There's another question from Dr. Amin Hanine. What about the quantiferon test for diagnosis?
Actually, this is the first time I am hearing about the quantiferon test, right? This is not available in Pakistan, and therefore might be that I don't know about it. But usually we take the biopsy and we send it for the histopathology or the gene expert test.
Dr. Ramil Groom, if you'd like to ask your question.
Yeah, please. First, thank you for this nice lecture. I would like to ask, in case you perform surgery, or even if you do biopsy and you confirm the diagnosis, you do your surgery or you do medical treatment?
Right. This is the next part of this presentation, that when to do the surgery. So thank you for asking this question.
Rami, wait, he will continue with the medical and then surgical treatment.
All right. So,
okay.
So if if there is no other question, I'm going to answer this question, that if we have diagnosed the tuberculosis, what we will do next. So this is another case. She is the 35 years old female who has D12 and L1 end plate destruction. If you see in the X-ray, the D12 L1 space is decreased. There is a mild end plate destruction, and when we do the MRI, so we will find that there is a hyperechoic area between the D12 and L1, and there is not much spinal cord compression. And this patient, although she had a pain, anorexia, and weight loss, but she did not have the neurological symptoms. So my question from you is that in addition to the anti-tuberculous drugs, because if you have diagnosed the TB, it is decided that it is going to be treated by the anti-tuberculous drugs, but you have to see whether you have to do the surgery or not. So what treatment options will you take in this patient? The rest, immobilization with brace, you will do the surgery, or you don't know?
Please answer within the next 60 seconds. Try 1, 2, or 3, and if you answer 2, try which subtype. Yeah. We have 4. We have 4 answering 1. Nice.
So you have reached basic. I think that as a spine surgeons, you know that what are the indications of surgery. So the indications of surgery, if I summarize it in a better way, is you can see the AO spine basic principles: the stability, alignment, functions, and biology. So if there is an instability, spine is unstable. And we know from our spine knowledge that what is an unstable spine. Unstable spine means if more than 2 columns they are involved, usually that is an unstable spine. Similarly, if you think that this spine has been destructed so much that it will develop the kyphosis, or it will have a progressive kyphosis in the future, then you can do that is an indication for surgery. Similarly, if there is a neurological deficit present, or especially if there is a progressive neurological deficit, that is an indication for surgery. Even if the neurological deficit is present, some people, they say that with the medical treatment, that neurology will improve. But if it is a progressive neurological deficit, then that is the definitive indication for the surgery. Similarly, sometimes in the TB, the patient will develop the paraplegia because of the kyphosis late in the disease. If you are suspecting that in the patient because of the increasing kyphosis, then that is an indication of surgery. Similarly, if there is a lot of paravertebral abscesses, that like I have show you in the videos, so where there is an abscess, it should be drained. That is the principle. And if your gene expert test, it came out to be the resistant anti-tuberculous drug, then it has been found that the surgery will help in the diagnosis, in controlling that resistant tuberculosis. So these are the indications of surgery in the tuberculosis of the spine. So before moving towards the next step, that which surgery you are going to select, right? If you have any question, you can ask about the indications of surgery, and hope I have answered that question.
Rami?
No. I'm still waiting until the end.
Okay. Professor Atiq, if you have a medical treatment, if you decide for medical treatment, some authors said that 4 weeks is enough.
Yes.
And you did not remove anything. You just diagnosed the patient, and you had no evacuation, and then you had to go for medical treatment. Is 4 weeks is enough for these patients?
Not at all. 4 weeks is not enough at all. Basically, what our practice is that we give the 5 drugs regime, the isoniazid, rifampicin, ethambutol, and pyrazinamide for, this is a tablet, and the streptomycin injection also in our patients for 3 months, right? And streptomycin is basically the intramuscular injection, which is painful. So usually the patient do not bear it for more than a month. So we give it for a month, and then we stop the streptomycin. Then after 4 months, we stop the pyrazinamide, and we will continue the rest of the 9 months for the isoniazid, rifampicin, and the ethambutol. This is our routine treatment for the tuberculosis. Yes, there are different regimes available. If the people they treat it, but it is none of them is less than 6 months. The present WHO recommendation is for the 6 months, and they say that even the tertiary tuberculosis, it can be treated if you continue these drugs for the 6 months. Then there is a DOT therapy. In the DOT therapy is that they ask the patient to come to the center after every 3 days or after a week, and then they give the anti-tuberculous drug by themselves, and they, to make sure that that the patient is compliant in taking the medicine. These are because this is the problem in the endemic area, that the people they do not continue the medicine for a long time, and this is basically leading to the resistant tuberculosis. So
Yes.
our routine is to give the anti-tuberculous drug for 1 year, but the 9 month, 6 month, 3 months regimes, they have been investigated, and some of the people they are using it. Even some people they are using it for 1.5 years also.
Yes.
And it depends on your follow-up and the healing. That basically, the problem is that how you assess the healing. We usually assess the healing with the help of the ESR and CRP. And if we see that the ESR and CRP is improving, we suspect that the patient is giving response from the this medicine. And the clinically, if his anorexia has been improved, it means that the patient is responding to the medicine. And the radiologically, when we have found that the fusion it has been occurred, we say that the medicine is effective. And if we do not find anything in these, if the patient is not improving with these measures, then we take the biopsy and send for the resistant tuberculosis. Similarly, when you are treating the conservative, means that without surgery, then must keep in mind that he might need the surgery later on during the treatment. So keep it under close observation and repeat the test after some time, so that you can assess that whether he is improving or not. Hope I answered the question.
Rami?
Thank you, Doctor, for your comprehensive presentation till now. I want to know if you want to go for medical treatment as a conservative, how you confirm your diagnosis without having a tissue? Because I am a rehab physiatrist, and we have dealing with some cases without confirmation that this is TB, which need 3 months to 1.5 year treatment conservative. Is it only radiological and lab, or do you have FNA or biopsy CT guided or etc.?
Actually, in our practice, in our endemic area, we in all of the cases which we are treating, we usually do not go for the biopsy. But in this modern era where all these facilities they are available, I cannot recommend that start the treatment without the biopsy, because a lot of other diseases are now becoming the common, the brucellosis, the pyogenic infection, the tumors. So you can do the CT guided biopsy. That's very, or nowadays people, they are doing the endoscopic biopsy under the local anesthesia. So you can send that biopsy and it will give you the, if you do not have the gene expert test, you can go only for the histopathology. So yes, the CT guided biopsy is indicated before starting the medical treatment. But in our areas where we are sure on the basis of the clinical examination, radiology and MRI, we start the empirical therapy, and then we assess it with the help of this ESR and CRP and the patient symptoms. If he is improving within 3 months, remember, the patient is not going to improve before 3 months, and he will develop the improvement. He will start having the improvement after the 4 weeks. We will continue with the medicine, and we are assessed after 1 month, 2 months, and 3 months. And remember, I usually ask my patient also and give them the instruction that once you have started the anti-tuberculosis drug, don't get panic or hurry to stop it, because if you are going to stop it, you are going to get resistant from these drugs, and we do not have so many options in the anti-tuberculosis drug. So once you have started the anti-tuberculosis drug, please do not, giving the drug is less harmful for the patient as compared to stopping the drug after once you have started the treatment. And you can assess it with the ESR and CRP and the patient's clinical symptoms. Hope I answered the question.
Thank you.
Dr. Ramil Groom.
Yeah, please, I would like to ask, do you have cases of recurrence?
Yes, we have. I will show you the one of my case in the last of this presentation, that they have the recurrence. And TB, it can recur after many years also. You have done the surgery or you have treated with the medical treatment, and patient will come after 3 years with the symptoms and the pus. And it is, but it is not very common that it will not be more than 1 or 2% cases who reoccur. And usually the reoccurrence, it occurs because they are not compliant with the medicine. If they are compliant with the medicine, they took the proper treatment, usually the TB, it has a good response. And one thing I must tell you, that tuberculosis can be, it can be healed without even treatment, because we are living in endemic areas. So we have seen many patients that they came to you without any treatment, and they have the healed tuberculosis. So
Okay.
if you have the immunity,
so
you can have.
So in case if you have been you did the surgery, after that you gave the treatment, medical treatment, and you noticed after 1 year or 2 years that you had failure of hardware, what you will do? Repeat the surgery, or you go for conservative treatment? And if you go for surgery, what you will use? Autologous or metal, or what else?
Rami, we're going to the surgery. We're going to the surgery.
I will come. Yes, this is basically the question of the spine surgery. This is not the question related to the tuberculosis. What I mean to say is that this is the question about the stability. That if your implant has been failed, usually the implant is failed if the spine is not stable, right?
Exactly.
The failure of implant means that the spine is not stable, and whatever pathology is there, it has not healed. That's why the implant after 1 year, under the stress, it gets failed. So either your surgery is not correct, you have guessed wrongly the unstable part of the spine, or the pathology has not been healed. So of course you will go for the surgery again. So we will deal with, I will show you the case after this chapter. Any other question?
Yes, we have Dr. Muhammad Khattab.
السلام عليكم ورحمة الله وبركاته.
Hello.
Muhammad Khattab from Egypt. Hi
أهلا
Saad,
وسهلا.
hi Atiq, how are you?
I'm fine.
I have just a comment. Sorry for being late. I have some stuff to do, but in my practice here in Egypt, that we send the patient for medical treatment by the pulmonologist or the infectious department disease. It is there is tight control for the anti-tuberculosis medications here in Egypt because the adverse effect. So we send the patient to this department to have the ideal dose and the ideal regimen. And we follow the patient regarding the musculoskeletal system or the spine in a frequent visits in our outpatient clinic to see if there is improvement, if there is neurological deterioration, if there is abnormal alignment. In these situations, we can do something. But regarding the medication, we didn't write it. We don't write it by ourselves in my country.
Thank you, Khattab. So it is the same in our country. We have extensive WHO TB program here, and we have the TB centers in all of our main hospitals. Even in our hospital, we have the TB center. But usually in acute, in the first time tuberculosis, which is not resistance to the TB, we start the treatment. We are allowed to start the treatment. But if patient develop any complication from that treatment, any resistance, then we refer the patient to that department and they will handle that case. Basically, they are relying more on the data from the primary tuberculosis of the lungs, and they treat the patient according to that regimes or that information that they have. And they do not give the anti-tuberculosis drug for more than 6 months. This is what in my experience regarding that department.
We have one more question from Dr. Haidar Al-Jbouri. Please, Dr. Haidar, introduce yourself and ask.
Yes, thank you very much. I couldn't catch this nice lecture, especially from Professor Atiq Al-Zaman. I'm sorry for that, but I want to ask you, Dr. Atiq, the PCR, the number of PCR, the copies, you depend on a special number of the copies. Sorry, if you mention it, I couldn't catch it.
PCR means you are talking about the test of diagnosing for tuberculosis.
Yes, the number of copies, 1,000 copy, 500 copies, or you depend on only positive or negative?
We usually depend on only positive or negative. And if I have any problem in diagnosis, I usually talk to the my medical guys. Basically, this PCR, it was not available in our country, but now from last 1 or 2 years, it is available. And the good news for our Pakistani friends is that it is available free for the tuberculosis patients. There are the organizations which are doing this test free even for the resistance of the rifampicin. So the answer of your question is that usually we see the positive and negative.
Thank you very much.
Any other question?
Yes, Dr. Atif, please continue.
Okay, so now we move towards the next case. He's 35 years old male. He had the involvement of the intervertebral disc space 12, 11, 10, 9, 8, 7. He's 67, right? And because of the lungs and the lymph nodes shadow, it is very difficult to see the lateral X-ray. And on the MRI, you can see that the sequestrated disc, it is lying in the intervertebral disc space, and there is an end plate destruction, and this material is going into the MRI. This patient was treated with the medical treatment because he did not have the neurological symptoms when the pain it was started. Initially, for the 3 months, he keep on saying that I have a pain, but nobody gives importance to it. And when the TB it was diagnosed, he was given the anti-tuberculosis drugs. He remained admitted in the hospital for 1 month, and during his admission, he developed the neurological symptoms and get paraplegic slowly, progressively. And so he came to me, and then I have done the surgery. So what surgical option will you select for this patient? The posterior decompression alone, the posterior decompression and instrumentation, the anterior decompression and cage, the anterior decompression, cage and instrumentation, and posterolateral decompression, cage and instrumentation.
Can you please answer on the chat, please? 1, 2, 3, 4, or 5. You have 60 seconds. Again. What type of procedure would you choose? Okay, we have 3 different answers. Okay, nice. Any others?
So what is the
what would you do?
trend? What is the trend?
Trend is 3 answers with number 3, anterior decompression and cage, and 3 answers with number 2, posterior decompression and instrumentation.
Okay, so the people, they are on the right path. So we have done basically in this patient the anterior decompression in the cage because he has the neurological symptoms, and we think that we can go anterior and can decompress the spinal cord. He is a driver, and he married after this operation. He has now 2 children, and he is back to his work. So you can approach through anterior, and this procedure was introduced in 1956, and it is called the Hong Kong procedure, in which you go anteriorly and you do the radicular debridement of the bone and cageous material. You decompress the posterior longitudinal ligament if the patient has the neurological symptoms. You decompress the dura, and you correct the deformity with the help of the stud graft. So you can take that graft from the iliac crust, or you can use the ribs, because in case of thoracotomy, if you remove a rib, it will increase your exposure. So you can cut those ribs into 3 parts, put the screws in it, and then you can put it into the for the reconstruction of the vertebral bodies. And you can do it as a standalone graft, or you can put the implant over it anteriorly, and this is then called the modified Hong Kong procedure. So this is basically the approach, and you can remove the rib from here. We are using these titanium cages. These are not the soft mesh cages. These are basically the hard cages, thick hard cages made of the titanium. It costs only the $30 in Pakistan. And it can prepare locally. We put the graft in this hollow cage, and we put it into the body. So this is basically the picture anteriorly. Now, in the special thing about the EB is that the anterior longitudinal ligament is intact. So if the anterior longitudinal ligament is intact and you retain the height of the body, that anterior longitudinal ligament, it will stretch, and it will prevent the slippage of this cage anteriorly, right? Similarly, the posteriorly, there is all the posterior structures, they are intact. The spinous processes, the posterior, this interspinous ligaments, they are intact. So you have just removed the necrotic bone, you have decompressed the spinal cord, and you have put this cage in the compression mode. So because there is a compression from the upper and the lower body over this cage, So that will prevent the slippage of this cage from the path from which you have introduced it, because it cannot go anteriorly, it cannot go posteriorly, and we put it in the anterior 1/3 of the vertebral body. So it does not need any instrument over it, right? Because if you put the instrument, the vertebral bodies will not be able to compress it from both sides. And if they will not compress it, it will not be so stable as the case if it is stable. So we do it in a standalone form. This is a hard cage. We fill it with the morselized bone graft. This is the morselized bone graft. We make it from the ribs. Or if we are doing in the lumbar region, we can take from the iliac crust. And then we put this graft into the cage, and we put that cage into the body. This is the removal of that cage in one of the cases. And this, you can see that how solid this bone has been formed, and this bone is going to be fused upper at the lower end, and they will work as a vertebral body. Then the other options that the people they take is the posterior approach. The posterior approach is good, but the problem with the posterior approach is that if you do only laminectomy without any instrumentation, without any going anteriorly, then that is basically in this modern era is a sin, which means that you have the anterior part of the spine is already diseased, and you have removed the normal posterior parts also, which makes the spine unstable, and this will convert the Port's disease to a Port's paraplegia. So it is not recommended, except if there is only a posterior tuberculosis, like in this case. Of course, you will go posteriorly and you will remove the posterior anterior elements, they are not involved. Or in case of the severe deformity, if you are planning some PCR or the removal of the posterior elements and then putting the transpedicular screw, you can go posteriorly. Then you can have a combined anterior and the posterior approach, which is called the caliform procedure. You go anteriorly, you do the anterior decompression and the graft, ribs or cage, and then you go posteriorly and you put the transpedicular screw fixation. It is like a 360-degree fixation of the spine. And then you have a posterolateral approach, right? This usually we do in the area of the thoracic spine where we cannot approach anteriorly. For example, from D1 to D5 because of the scapula or because of the sternum. So in that cases, we go from the lateral side, give the periscapular incision, remove the part of the transverse process and the ribs, and reach the anteriorly, and then remove the necrotic tissue in the body and decompress the spinal cord, right, like this. And this is the incision that is given in the costotransversectomy. Then in the posterolateral approach, this is the popular approach nowadays, that you do the transforaminal interbody fusion. You go through the transforaminal region and you remove the anterior necrotic bone and disc, and then you put the cage there, and because you are posterior, so you put the transpedicular screw fixation. This is just like doing the anterior surgery through a posterior window. Basically, your target is the anterior, and you have made the window from the posterior, and you reach the anterior part of the spine, and you have done your work, and then you put the transpedicular screw fixation. People like to do this because they are familiar with the posterior approach, and they found that with this you can do the debridement, and you can also do the 360-degree fixation. So this is another way of doing it. There are expandable cages which you put from the window through the posterior. You put the cage in it and then you expand it. It will expand in upper and lower direction so that it fits into the body. We do not have a good experience with these expandable cages, and we no longer use, because later on it gets collapsed. It's expanding mechanism, they are usually not very effective because there is so much forces they are present in the anterior part of the body. And then the role of the endoscopic and the minimally invasive spine surgery. One role I have already told you is the biopsy. You can do the endoscopic surgery for under local anesthesia for the biopsy, and then you can use different frames to keep this surgery minimally invasive. The outcome of the tuberculosis spine surgery is very good. Even after 2 years or 3 years of neurological loss, we have seen that the neurological recovery it occurs. It might be complete or incomplete, but people they improve even after the 1 or 2 years of neurological loss, which is not the case in rest of the causes of the neurological loss. So it is a very rewarding surgery if you do the proper decompression of the spinal cord and make the spine stable. In 93% of the cases, they have good recovery. This is the systemic analysis about the whether we do the anterior or the posterior surgery. They have the same clinical outcomes, because basically the clinical outcomes, it is assessed on the basis of the healing of the disease and the decompression of the spinal cord, and it has a very good result. So both anterior and the posterior, they give the correction of angle, the loss of correction it occurs, the fusion rate, and the complications after surgery. On the basis of these criteria, they have the same outcome in the literature. But our experience is that the anterior pathology must be approached anterior. Why? Because the abscess, everything is present anterior. Abscess, necrotic bone, compression, the biopsy tissue, the reason of kyphosis, the fusion you want. So everything is anterior. So why you want to go posterior? You want to go posterior because you are familiar with the posterior approach. That is also not wrong. But if you are familiar with the posterior approach, you can do that. But this is the reason we think that if there is an anterior pathology, go anteriorly. Do not disturb the normal posterior environment. This is also equivalent to the biomechanics of the spine, right? The spine is like a crane. There is, this is the spine, this is the anterior body, and these are the muscles which are holding it. So if we break this posterior normal rope, which is normal in case of the TB patients, and the anterior part is already injured. So we are basically disturbing the normal structures, and the structures which are made by the god, it has a better strength as compared to the, we are going to fuse the posterior part. So, and we all know that at 30 degree of kyphosis, 80% of the vertical forces, they are converted to the translational forces. So if you remove the posterior elements, you have made a depth of a column, and all cylinder long columns, they collapse when structurally weakened in the middle. So it is better to get the height of the anterior column as compared to decrease the height of the posterior column, and it is better, you can do it better from the anterior side. And secondly, if you correct the deformity from the posterior side, you are basically removing the column, and then you are doing the shortening of the column, which will decrease the height or the length of the spinal cord, and it will cause the compression of the spinal cord, which can lead to the neurology. Right? So spinal cord blood flow was markedly increased, and then it is decreased if you do the kinking of the cord like this. So it can lead to the paraplegia. So we are doing this dealing with this tuberculosis of the spine anteriorly at our Burki Trust Teaching Hospital under the mentorship of Professor Amir Aziz. So he is doing it from last 15 years, and we are actually very satisfied with this procedure. So we have done the surgical audit, and we have found that we have done more than 1,400 cases of the tuberculosis spine at our center, and we have applied these stand-alone cages without instrumentation at almost every level, from cervical C1, C2 to the thoracic spine. And in the next few slides, I am going to show what are the results of this surgical audit and how we have improved and how we have applied in different cases. So we do almost 100 cases a year from 2006 to 2018, and both male and female patients, they are involved. They belong to the low and the middle socioeconomic status and the rural areas. And most of the patients, they do not know that they have previous history of TB, even if they have. And the strange for me also that most of the cases that we treat, they do not have the neurological symptoms, but they have the unstable spine. That's why we have done the surgery. The most of the cases, they are usually at the junctions. The L3, L4, D12, L1. These are the areas where most of these cases they are present, and usually only 25% of the patients they have presented within 3 months of the start of their symptoms. So there is a delay in the diagnosis and the presentation of the patient. And we have done the anterior decompression and standalone cages, and we have good results in almost 90% of the cases. And the kyphotic angle, this is the acute correction of the kyphotic angle, which occurs from 11 degree to 30 degree with the help of the standalone cages. And the functional status of the patient, it has also been improved. This is another paper that we have published, and this is to counter the concept that the standalone cage later on it is going to be collapsed and it increases the kyphosis. So this is the people who do from the posterior. They think that the kyphosis, if you do straight away anteriorly, then it is going to cause the increase in the kyphosis. So we have found that there is no added fixation required for supporting cages in the cages spine, and basically this is based on the cervical spine. So before the surgery, the mean Bob's angle was 39, which has remained at minus 5.51 after the surgery. So now I will present few cases of different regions of the spine, from cervical to the lumbar. This is the cervical spine case, and he is a Mazhar Sultan. Yeah, not sure the name. He is 28 years old male, and he has upper motor neuron signs, and he presented to us in 2008 with the tuberculosis of the C2 and C3, and it is also compressing the spinal cord. So we have done the anterior decompression and the standalone cage at C2 and C3, and this is the follow-up after the 11 years. There is no increase in kyphosis. The lordosis of the cervical spine is maintained. There is no collapse of the vertebral body, and patient is okay. This is the incision of the patient. And the reason is that the anterior ligament is intact and their tissues, they are intact, and it is in the compression mode. We have put it into the anterior 1/3 of the vertebral body, and the forces, they will not allow it to slip anteriorly or the posteriorly. So this is another case. He is a 29 years old male, and he is presented to us in 2008 with pain and progressive weakness of the both lower limbs. He has a tuberculosis of D5 and D6. Right? And the MRI, it shows that. Another thing I want to emphasize here, that do not decide the destruction of the body on the basis of the MRI, because it will show the edema also. So when you are planning the surgery, plan the surgery on the basis of the destruction of the body which is visible on the X-rays, that how much the body it is destructed. Because otherwise you will you think that you have, in this case you can think that you have to remove the this body also, but clinically if you go there you will find that it is not so much destruction. So we have done the anterior decompression and cage, and you can see this is slight slanting of the cage, but still it is stable. It is a standalone cage, and this is the follow-up after 4 years. This is after 5 years, follow-up after 6 years, follow-up after 11 years. There is no collapse of or increase in the kyphosis in this patient. So you will find that the cage, it remains in the same length, and it will not, patient will get all right even after the 11 years of follow-up. And he is performing all his functions, his range of motions, they are okay, he is happy. She's a 35 years old female, and she presented to us in 2008, and she has a D4 and D5 tuberculosis. She was developing the neurological symptoms. That's why we have done the surgery in it, the anterior decompression and cage at D4 and D5. This is the follow-up after 5 years. After 8 years, after 11 years, and if you compare it, there is no collapse or there is no implant failure because there is no too much implant in it. And she can perform all her activities. This is the TB of the D6 and D8, right? Again, anterior decompression and cage has been done. And if the cage is on the one side, don't think that you have done something wrong, because we usually go from the left side and you remove all the vertebral bodies from the left side, and it is difficult to go on the other side of the body because the segmental vessels, they are lying there, and it is difficult to control the bleeding if you go on the other side. So this is the follow-up after 5 years, 6 years, 10 years, and patient is fine. If you compare, there is no compression or the loss of kyphosis or the failure of the implant. This is D12 and L1. This is the junctional area of the spine, the most mobile segment, anterior decompression and cage, and 7 years follow-up. Right? You can see that this cage is lying just a little bit at the angle from the very first day, and even then it has not been, it hasn't displaced after the 7 years. Now see, this is 51 years female. Now we come to the lumbar area. In the lumbar area, which is the mobile part of the spine, this is the L3 and L4. Anterior decompression and cage has been done without any anterior and posterior instrumentation or 360-degree fixation, and the patient is okay at the 7 years follow-up. And this is the clinical results of this standalone cage. Then we also, in the children, we do also the anterior decompression, and this is standalone cage. But only thing that we do is that with the same incision, we also do the fusion of the posterior facets joint. So that the crankshaft phenomena, it did not occur. If you fuse anteriorly, the child will keep on growing posteriorly, and it can lead to the increase in the kyphosis. So this is the pus of this patient, a lot of pus he had, and then we put the cage in it, and this is the anterior decompression and cage, immediate post-op X-ray, and this is the follow-up after the 3 years. In a pediatric patient, there is no loss of lordosis. You can see that the lumbar lordosis is still present in this child. So these are few other cases: 2006, 2019, right? 2009, 2019, 2005, 2019, no collapse. 2006, 2019. This is the cervical spine, and see that almost 2 vertebral bodies has been removed. This is the redo case. There was one question that if you have a failure of the implant, or if there is a reoccurrence of the spine, this tuberculosis, then what we will do, we will do the surgery again. So when there is a reoccurrence, the upper and the lower vertebral bodies, they are also destroyed. So see, this is a stand-alone cage in the most mobile part of the spine, and see the length of the cage, almost 3 vertebral bodies has been crossed, and even then it did not dislodge, or it did not causes the increase in the kyphosis or the loss of lumbar lordosis. This is an interesting case. He's a 60 years old male who has presented with a thyroid and the tuberculosis of the spine. So there was enlarged thyroid, so we called the general surgeon, and he first removed the thyroid, and then we have done the anterior decompression and the cage in this patient. Right? See, we have removed 2 vertebral bodies and we have put the long cage in the cervical spine. She is another female. She came with us with the paraparesis. We thought that she has an intradural mass, and when we open that female, she basically has intradural tuberculosis. So you can have the cases of the intradural tuberculosis. We send it for biopsy, and it came out to be the tuberculosis. So these are the different cases to show that the anterior decompression and cage. So early diagnosis and treatment can result in complete resolution. Advanced destruction of the vertebra results in permanent disability, which requires complicated surgery for correction. If paraplegia develops, 80 to 95% can still recover with adequate treatment. Anterior decompression and standalone titanium heart cage with bone graft is a valid method for tuberculosis of the anterior spine. So any question regarding the approaches or indications of surgery? Saad, we cannot hear you. You are mute, I think.
Yeah, sorry. This was very nice lecture, a very nice demonstration of surgery for this kind of pathology. Although we don't have a lot of experience in that, but I like the idea of doing single cage, single approach, and getting enough for a long time without going for 360 degrees. We have a lot of questions. First of it will be from Dr. Fadi Al-Hadidi. Fadi, unmute yourself.
He is asking how you deal with drug-resistant cases and how frequently you see posterior arch cases.
Yes.
Posterior arch cases is very rare. TB is usually involves the anterior body end plates and the disc spaces. But we have seen the posterior, as I have shown you one. I have another one. I was seeing my report yesterday, and we have done the posterior decompression, and they have done well. Regarding the resistant tuberculosis, you treat the resistant tuberculosis aggressively, and aggressive means that is the one of the indication of doing the surgery and doing the proper debridement, removing all the necrotic tissue. And for the medical treatment, we take the help of the medical people and the TB expert for the resistant tuberculosis, because this is the last chance to treat them. Now there are 3rd generation drugs, they are available, but still that is a serious matter, and we want the medical people to deal with it. Hope I answered the question.
Do you have same approach for active cases and healed cases? Okay. Do you have any experience with posterior only approach?
Do you have the same approach for active cases and healed cases? No, we do not have this. Same approach means that anterior approach. Yeah, even for the healed cases, we like to do anterior. Why? Although we are not able to get the full correction, might be. All in our hands, we have found that actually that I already shown a lot of cases, so I don't want to show those cases also. I haven't put it in my presentation, but we have achieved the correction anteriorly. Although it is not up to the standards, I say that people they expect too much. The surgeons basically they expect too much. They want proper correction of the corpse angle. But believe me that even from the posterior surgery, considering its mortality and morbidity, I prefer the anterior surgery for the correction of the deformity even. But in case of rigid deformity, I usually go from anterior, and then if needed, go from the posterior. But it depends case to case. Although we prefer the anterior surgery if it is not a very rigid deformity.
Dr.
Hope I
Khattab,
answered.
Thank you, Atiq. Excellent presentation and marvelous experience. 1,700 tuberculosis cases is a really huge number. And I think the key of success in your series that early diagnosis and the treatment, as you stated in the first sentence in your take-home message. Because in my practice, when I go late for these cases with spondylodiscitis anteriorly, there is always a lot of adhesions, and it is not an easy way to access anteriorly because of the amalgam in the soft tissue and the fear of hitting the great vessels and so on. So nowadays, I used to do all from posterior, and I prefer that. Of course, to go anterior early in the disease, early with the presence of the abscess, it can create something like safe corridor to you to approach the spine. My only comment that in my experience in the cervical spine, when I used to put anterior cage and do corpectomy at multiple levels, you know, I faced one case with cage alignment post-operatively. So I decided in any case, when I do corpectomy, especially in the cervical spine, I used to augment posteriorly bilateral mesh screw. That's put me in a better, you know, post-operative relieving situation.
In which case? What was the diagnosis? Yeah?
Spondylodiscitis infection.
Pyogenic or TB?
Yes, pyogenic.
Pyogenic. There is a difference between pyogenic and TB. In the TB, the anterior structures, basically it is a slow-growing disease. So the anterior structures, they are intact. You are not disturbing the anterior longitudinal ligament, anterior adhesions. The adhesions has been formed. So you are not going to disturb that when you are putting the cage. This is the difference between the TB and the trauma. If you ask me for the trauma, I like to do the posterior, because in that case, I want the ligament protexis, I want the bones to heal, because that is not a pathology. But in case of TB, the structures, they develop or they form in such a way that you can rely on the standalone cage.
And regarding the post-operative protocol, you put the patient in cast, braces. What is your post-operative protocol?
Yeah, that is basically, this is another difference between anterior and posterior. We do the anterior surgery and we put the patient on in a brace. We keep the patient in brace for 6 weeks to 3 months, depend upon the fusion. This is basically the difference between if you do the 360-degree fixation and if you do the only anterior approach. But for our patient, with the lower socioeconomic status, TB is also a disease of the lower and the middle class. It is the people, they are more happy with this mode of treatment rather than the expensive implants that we use from the posterior.
Thank you.
Okay.
Dr. Haidar?
Thank you very much. I want to ask Professor Atiq, could we use only allografts in putting this cage? And by the way, is you the pioneer of this standalone cage? It's very, very nice philosophy, I think. Thank you very much.
I am not the pioneer of this cage. Basically, Professor Amir Aziz, he is my mentor. He is the pioneer of this cage. And we as a student of him, we are following it and we find it a very effective method, number one. Number two, your question was, sorry, I forgot. What was his question?
About the allograft. Could we
allograft.
Use only allograft per se?
Yeah. Before this cage, in 2000, you say 2, 3, 4, 5, around there, we were using only I have shown you the slides that we use only the graft instead of the cage, or we can also put the ribs.
No, sorry, Dr. Atiq. I want to ask about by the pyramesh, we put only allograft, not autograft. You use the paramesh or the cage, but we put in it the allograft only. Could we do this, or we should have autograft with it, or what your experience in that? Thank you.
Actually, allograft, they are not available in our country yet. So we do not have the experience with it. But of course, this is basically the science of graft. So you can put the allograft. The purpose of the graft is only to just have the osteoblastic activity there.
Thank you very much.
Saad, your mic is off.
Firas, please. Firas,
Yes, please. Yes, please. My question just was about the timing of surgery in relation to the timing of medical management. So, of course, given that there is no acute neurological deficit, the patient has no acute neurological deficit. So, do you go for surgery immediately, or you wait some time with the medical management before going for surgery?
Actually, we are not doing the surgery for treating the tuberculosis. We are doing the surgery for two reasons. One is that there is an instability, and number two is there is a compression on the spinal cord, right? Third is that regarding the TB is that if there is a too much abscess, or if the patient is resistant to the tuberculosis drugs, these two things, you can say that it is related to the tuberculosis. But basically, we are doing the surgery according to the surgical principles, that where there is an abscess and the necrotic tissue, remove it. Where there is an abscess, remove it. Number one. Number two, if there is an instability. And number three, if there is compression of the spine. So these are the three indications of surgery. If the spine is stable, if there is no compression of the spinal cord, and if there is no resistant TB, or if there is no excessive pus there, you can do the conservative treatment. And even the people, they have found, if you see the literature, the people, they say that even the neurological recovery, it occurs with the medical treatment. But if the patient has developed recently the neurological symptoms, I cannot convince myself to refrain from the surgery if I have found that there is a compression of the spinal cord. Hope I answered the question.
Yes, thank you so much.
Atiq, may I ask you regarding the cage size? I saw some cages in your cases that they are beyond the boundaries of the vertebral body. And in such cases, I am afraid, especially in the cervical spine, to hit the esophagus or soft tissue anteriorly. Do you have any drawbacks from the size of the cage, or it is just a fear in our hand as a surgeons, and it is okay, no problem? What is your experience?
Actually, by principle, you have to put the cage into the anterior 1/3 of the vertebral body. This is the same principle which you follow in the P-LAF or in the PEEK cages, that you want to put the cage into the anterior 1/3 of the vertebral body. And usually, the half of the cage, deliberately we keep outside the vertebral body because of the stability, or because of, so that it can bear the compressive forces. And according to the liver arm principles, if the far you go, the better you can achieve the correction. So it is our aim that we put these few threads outside the anterior part of the vertebral body, even in the cervical spine. It leads to the complications. Sometimes we have opened for the redo surgery, and we have found that there is aneurysm of the aorta. We have seen, I think I have seen two cases, such cases where there is aneurysm of the aorta, but we did not find any case of dysphagia or esophageal perforation, except if there is an acute injury to the esophagus, it occurs.
Okay.
Hope I answered the question.
Yes. Thank you, Professor Atiq. But my last question before we conclude. You had the revision for one case. What was the reason for that?
There is a reoccurrence of the tuberculosis.
Recurrence of tuberculosis.
If it is not responding to the medical treatment, the tuberculosis the process of tuberculosis destruction due to the tuberculosis bird, Mycobacterium tuberculosis. It keeps on destroying the rest of the bodies where you have put your cage. And when that bodies they are going to destroy it, the cage can displace, or there will be instability, there will be formation of the pus. So these are the reasons. We do many redo cases. It is not that this is the definitive procedure and all of our cases they get all right. So people they have reoccurrence. People they have resistant tuberculosis because this gene expert test it came just a year back, and before that we start with the simple anti-tuberculosis drug with all the patients, and when they do not respond, then we came to know that they are resistant to the tuberculosis. So this procedure is not without complications. It has its complications. The only and this is the problem with the anterior approach. When you go anteriorly, there are dangerous structure lying outside. The surgeon don't like. There is a pulsating aorta in front of it, and if you damage that vessels, it can lead to death. Because if the vascular facility is not available. Similarly, and with this experience, we usually avoid the anterior cage in L4, L5, and L5 and S1. Because in those areas there are a bunch of vessels. Basically, this external carotid artery, this aorta, it is going to be divided in these regions, and then there are a lot of branches in front of it. And if you damage even that branch, it bleeds to hell. Secondly, in the lumbar area, the psoas muscle is a problem. It is difficult to work through the psoas, and there are the structures lying inside the psoas muscles. So we have now started doing the P-lift in the L4, L5, and L5S1. And above that, we usually prefer the anterior decompression and cage.
Dr. Khattab,
Atiq,
Yes.
may I ask you about tuberculous paraplegia? If patient presented to you with paraplegia, maybe it is a mechanical due to the presence of deformity, or due to compression by caseous material, or due to an end arthritis obliterans, which can be anticipated in cases with chronic granulomatous diseases. So if you have patients, they recovered and it was due to only mechanical, or some cases have end arthritis obliterans and they didn't recover. Tuberculous paraplegia.
I have shown this slide that it has a very good recovery, this tuberculosis. Even the patient, if they came after 1 year of neurological loss, the patient, they benefit from the surgery. At least 2 or 3 grade improvement in the neurology occur in these patients, even in old age patients. So you can be optimistic in the tuberculosis, even after, if the patient coming after 2 years of paraplegia and he has the compression of the spinal cord and you do the surgery, they can respond very good. So it has a very good prognosis.
Yeah, is there is a place for minimal invasive option in your hands? Let me say, for example, if patient with spondylodiscitis, tuberculous discitis, or TB spondylitis, we can go minimally invasive by endoscopes, or even evacuate source abscess by pigtail percutaneous approaches in the radiology department, and cover with antibiotics. Is there a place for that in your practice?
No, we are not doing it. We are not doing it because we have only one endoscope, and we do not want to get it infected, use in infected cases.
Okay.
But the people, they are doing the endoscopic biopsy, and of course the drainage of the pus, it can be done. But there is no, I can't say the benefit of endoscope in doing the psoas. Yeah, we do the percutaneous drainage of the psoas abscess with the help of the ultrasound. We asked our radiologists, they do the percutaneous drainage of the abscess. So we are doing it, but we haven't used the endoscope.
Thank you, Atiq. Great presentation. Thank you, Saad, for your activity and enthusiasm to spread and exchange knowledge, which is actually one of our message as a spine surgeons and the human being, to spread and exchange knowledge between all medical practitioners.
Thank you. Thank you,
Pratap.
Fatah.
You are also doing a very great work. One question I want to answer. Somebody has asked why. Fadi has asked why you prefer Harm's mesh cage over peak cage. Because this first, that this is not our cage is not the flexible cage. It is a hard cage, right? Hollow hard cage. It is like a water pipe which you are using, the hard pipe. It is just like that thing, and it is very cheap because we are preparing it locally. So it is only $40. The peak cages, they are very expensive. Number one. Number two, they were not available few years back in our country. Number three, their sizes, they are not of this much. I have tried in P-lift cases, and we are doing in P-lift cases. If they are simple P-lift case, we do the peak cages, only the minor destruction of the end plate, because the maximum size available was 12 in that peak cages. So these are the three problems due to which we are not using the peak cages, and we prefer this this cage. But putting this cage from the posterior window is very difficult, because you cannot rotate it like the peak cages, and you have to make a large window to put this cage in a compression mode. That's why the people, they have made the expanding cages. The expanding cages are that those are the two cages, and they are overlap with each other. They put the cage inside, and then there is a screw head over it. They rotate it, and that cage, it expands. So they have made so that they can put from the posterior into the anterior. So this is the reason. Hope I answered that question also.
Yes, you did. Thank you very much, Professor Atiq. It was a very nice, comprehensive lecture, and we wish you all that you have benefit from that. We wish you Ramadan Kareem, because it will be next week, and we hope that Ramadan will become a very nice memory of COVID-19, not a very bad memory.
Thank you. Thank you very much, Saad, and all the participants who have listened to my advices. Thank you.
Thank you very much. Good night.